Hey there, EKG of the week number 2. This is a two-parter actually, so we're going to start with transmission that was made to the hospital. We'll start with the pre-hospital EKG, and then we'll get to the hospital EKG itself, just again for practice. So we'll say that the context is sometimes important. In this case, it's a adult with shortness of breath that this EKG was performed on. So let's look at the old EKG. And again, if you need a second, and probably it's a good idea, go ahead and pause, make an assessment of this EKG, and then we'll pick it back up in just a second. All right, hopefully you've had a second there to make an interpretation and do whatever looking at you wanted to do. So let's run through this thing. So again, rate, rhythm, axis, intervals, blocks, ischemia, infarct, patterns, and then an overall impression is the way we'll go through this. So rate, again, the way that I like to do it, I like to just count QRSs, but we could do it based on the space between them. But when we count our QRSs, this is a 10-second strip. So we got 1, 2, 3, 4, 5, 6, 7, 8, 9, and not quite a second one. So about 9. Again, 10-second strip. There are 6 of those in a minute, so 9 times 6 is 56, and that corresponds pretty well with the block method if we were to go through that. But we'll say there's a rate somewhere 56, 60, something like that. A bit slow for an adult. not 30s, not pacing, but a bit slow. All right, so rate somewhere around 56 or so. Rhythm, let's look at the rhythm. In this one, there is no actual rhythm strip, but when we look, we see QRS complexes that they all look more or less the same, in that I don't see any like big wide ones to suggest a PVC or something. And there seems to be a P wave before each QRS, P wave before QRS, P wave before QRS, P wave before QRS. That all seems to check out. They become a little bit less visible as we go through here, but you can still see it in like lead 3 as we kind of switch side to side. So it looks like there is a P wave before every QRS complex. So we will go ahead and call that sinus rhythm. When we look at the axis, again, I'll just put it up there. If you really care about axis, you could go through the trouble of like figuring it out, but it's positive in lead 1 and lead AVF. So we think it has to probably be about right. And it's also positive in lead 2. Therefore, this seems to be a normal axis on this one. And again, don't worry too much about the axis if it doesn't make a whole lot of sense. For most of us, it's really not going to make a big deal in terms of pre-hospital care. All right, so we've got rate 56, rhythm, sinus rhythm, axis, looks more or less normal. Rate, rhythm, axis, intervals, and blocks. So let's look real quick. We will kind of eyeball a lot of these things. Here's our PR interval, start of the P wave to the start of the R wave or the QRS complex here. And it looks like that is probably under the space of one big box. So that looks normal. QRS looks if we look at these things, it's supposed to be under, again, 3 little boxes, and the QRS looks in this case be like a box and a half, something like that, a little box and a half, maybe 2. So certainly under 3, so normal QRS width. And then broadly looking at the QT interval, again, look at one QRS segment and versus another QRS segment, and does the T wave end before about halfway through, which would be right about where the center of that cursor is. And it looks like the T wave does end before that. So this is probably not a real long QT. Again, that's not a measurement. It's just an eyeball way. You can get a little bit thrown off, but it doesn't seem to be a long QT in this case. So we'll say that we don't see any obvious changes in the intervals or anything that looks pathologic, and no obvious blocks associated with it, like again LF bundle branch block or AV block or anything like that. So rate, rhythm, axis, intervals, and blocks. Now let's look for ischemia and infarcts, i.e. let's look at the ST segment first. We're looking for ischemia, and then we'll look for STEMI itself. ST segments and T waves. This looks pretty. We don't see a whole lot of change there. And you can do it, based on however you want. I'll tell you what, let's start with the precordial lead. So we're looking anterior lead because this follows a vascular distribution. Looking in the anterior segment, we don't see any obvious ST changes. There's a little bit of T wave inversion there. Looks up, it's starting to get just a little bit of maybe elevation there in the ST segment, no flip T waves, but maybe a little bit of elevation there. It can sometimes hide a little bit. It's under a millimeter out there, it looks like. Those are again, looking at the precordial leads, V1, the V leads essentially. When we look at the lateral leads here, when we look at, here's the segment that we're going to compare it to. It looks like the ST segment is maybe down a little bit. Hard, it might be just a little bit of an optical illusion, but it looks like the ST segment is maybe a little bit below the line between the T wave and the P wave there. Probably so. And then when we look at lead AVL, it looks like there's some definite ST depression there. That's definitely below, and the T wave is inverted there. So that looks abnormal. This is either a reciprocal change or this is potentially ischemia. Something looks abnormal with AVL and maybe a little bit with lead 1 as well. When we look at infarcts and that kind of stuff, looking in the inferior leads, now we get to the big spot, the money shot. Here it is. We see there's our TP segment. Looks fairly straight. And then that ST segment looks bumped up above the TP segment, maybe a little bit. And again, you can be fooled a little bit. It's a millimeter that makes it actually significant. When we look down here, that might be it. This one looks pretty convincing. That looks like that ST segment is a bit elevated. It looks like it's sort of doing that tombstone thing that we think about. And we see a similar looking thing in lead AVF. That ST segment looks like it is up. It's maybe a millimeter right at it, but these are pretty small QRS complexes too. So in comparison to the size of the QRS complex, that looks like that's probably probably pathologic. That one in particular right there, that looks like a STEMI to me. And we see that in 2 leads that follows a vascular distribution. So this is concerning for ST elevation and potential STEMI. And that corresponds real well with some lateral depression. Remember, wherever you get ST elevation in the leads that are on the other side of the heart, so if it's looking at the right side, on the left side, you probably will see some reciprocal changes or changes in the opposite direction. So ST elevation here, ST depression in the lateral leads. So that fits pretty well with potential infarct, inferior infarct in 2-3 AVF, the inferior leads. That seems like a STEMI. When we look for patterns and anything else, I'll just tell you that I don't see a whole lot of other characteristic patterns like WPW or anything like that looks really awful. And so, or peak T waves or something to suggest that it's hyperkalemia, something like that. So our impression on this one is going to be that we look like we have an inferior STEMI with reciprocal changes in lead 1 and AVL. 1 AVL, and there's the STEMI down there. That again is the pre-hospital EKG. For fun, let's look at the in-hospital EKG. Now, again, we've already kind of gone through it a bit, but we'll just see if it looks a little bit clearer, as sometimes it does now that we got good lighting and we got the patient more or less still. What we've got here, all right, don't lose sight of stuff. Go through it in a organized process. So rate looks to be, if we count these up, there are 6 QRS complexes down across the bottom there. Or I'm sorry, there are 10 QRS complexes down across the bottom. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, which times 6 gives you a rate of 60. So that pretty well corresponds with what we were seeing before. Rate rhythm, it looks like there are P waves before every QRS. P, QRS, P, QRS, P, QRS, P, QRS, et cetera, all the way through. This one just looks a little funky, but I think that's still sinus rhythm. P before every QRS, P before every QRS. So this looks to be sinus rhythm. Rate rhythm axis, again, don't worry about it too awful much, but it looks like they're up in positive QRS complex in 1 mostly, positive QRS complex in 2 mostly, and positive, in fact, in AVF as well. So this should be somewhere around a normal axis. The intervals look, well, I'll just tell you without going through each one of them, look pretty much okay. This looks looks like it's starting to border on a little bit of more than a box between the start of the P wave here and the start of the QRS segment here. But that's not real clear. And I think it still falls under that one box kind of rule. So we'll say that there's no blocks that we obviously see. If it was if it was more than a box there, we'd call it probably a first degree AV block, and we'll talk about that at some other point. But we don't see it here. Let's look for infarcts and that kind of stuff. Get these things out of the way for a second. In this one, we mentioned before that there seems to be some changes. Here we look at V2. That looks pretty much okay. In V1, no obvious things there. V3, no obvious ST elevation or T wave changes. V4, starting to look a little funky there, but not too awful bad. But that looks like that ST segment where that cursor is might be a millimeter or so above the TP segment there. This one, not as convincing, but it's a little bit wandery, so hard to say. Still looks a little funky right here, and, doesn't quite meet a small box in elevation, but it might be there. This one looks a little bit more concerning, though. That looks like it's approaching at least one small box of ST elevation above that line. So I'd be worried about that guy. So maybe there's a little something going on. Again, if you think about we sort of start here and we go like septal leads, anterior leads as we're walking our way through, and then we get out into some of the lateral like V6. You see up in lead 1 and AVL, the lateral leads that we usually think of. Looks like the ST segment is beneath this line here, so we'll call that ST elevation. Same thing here, pretty pronounced. Not ST elevation, ST depression. Same thing here, ST depression in lead AVL. So we've got ST depression lead 1 and AVL thus far, a little bit of ST elevation in V6. Let's see if we can find anything else. When we look at lead 2, here it is again. That, depending on which TP segment you look at, maybe not actually elevated, but it certainly has the appearance of it. Not sold on that one thus far. I look down at lead 3, this guy here, and boom, that's got it. So here's the ST segment right where the cursor is. Is it up a millimeter from the intervening, the TP segment here, this baseline? It sure looks like it is, and it's got that tombstone-y kind of appearance. So that's concerning for ST elevation. And then we see sort of the same thing here again, little tiny QRS complex, but that looks like it is truly elevated above the line to me. So we've got what appears to be significant ST elevation, we believe, or at least characteristic looking ST elevation in lead 3 and AVF. We have ST depression on the other side of the heart in lead 1 and AVL. This looks like a STEMI to me. This is one that I would call activate the cath lab. Yep, this seems like real deal, even without looking at the patient themselves. So to hit it one more time here, see what we got. We got a rate of 60. We did our rhythm, which looked to be sinus. The axis, who cares? But it looked all right. Intervals and blocks, and again, who cares for our standpoint? Intervals look normal. We don't see any sign of blocks. How about ischemia and infarcts? We see ST elevation in the inferior leads and maybe a little bit in the lateral lead like V6. Which can correspond as the right coronary wraps around the backside of the heart. But we also see ST depression in lead 1 and AVL, so that's concerning for reciprocal changes. In this setting, this looks like an inferior, maybe inferolateral STEMI, but certainly some lateral ST depression, which would kind of strengthen that case as a reciprocal change. Patterns otherwise, I don't see any peak T waves. I don't see any obvious stuff that just rings a bell to me. So we're going to call this impression inferolateral STEMI. And that will do it for EKG of the week. Keep watching for more updates. Leave a comment if you have any questions or if you just feel like you need to say something. And otherwise, we'll catch you next time. Stay safe out there.